in the last lecture we have discussed how Parkinson's disease is managed surgically, both ablation and with DBS. So we'll be going forward with discussing the management of other disorders, including other non-movement disorders and movement disorders apart from PD. So first we'll discuss the management of tremor, followed by that of dystonia, and then functional neurosurgery for other disorders. So coming to the surgical management of tremor cases, so if you have attended the previous lectures, we have already discussed the basic pathophysiology of tremor disorders. We'll just revise it a little bit here and there. Important things to remember about tremor disorders are there are two basic classifications. One classification is just that you classify them into essential tremor, and all the other tremor disorders fall into complex tremor disorders. So essential tremor is the main tremor disorder where the only problem is just tremor. The tool that we use to evaluate the severity of tremor disorders in essential tremor is known as the Farn-Tolosa-Marin Tremor Rating Scale, the FTM TRS basically. The essential tremor cases are managed with the first line for only for severe tremors, that is with propranolol or primidone. For any patients who are refractory to propranolol or primidone, they can undergo either DBS or receive second or third line medications. The second line medications include clonazepam, alprazolam, and topiramate, and third line medications include clonidine, acetazolamide, or flunarizine. So the important thing to remember is that for a patient to undergo DBS for a case of essential tremor, they should be refractory to at least the first line medications, and they should obviously have severe tremors. Now, the targets for patients who are undergoing DBS or essential tremor could most likely be the VIM thalamus, that is the ventral intermediate nucleus of the thalamus, that is the most commonly used target. But a newer and upcoming target is the caudal zona incerta. And another important thing to remember about essential tremors is that voice and head tremors do not reliably improve with DBS. And so these should not be the primary indications for DBS in cases of essential tremor. Coming to other tremor syndromes, which could be considered for surgery, these are usually less common and they are more complex. That is why they're called complex tremor syndromes. And surgery could be considered for some of these, such as a cerebellar tremor, a Holmes tremor, a thalamic tremor, and orthostatic tremor. Cerebellar tremors are frequent problems in patients who have MS. Holmes tremor is also basically just your rubral tremor. Thalamic tremor is an action tremor which is caused by lateral posterior thalamic strokes. And an orthostatic tremor is basically a tremor of legs and trunks which occur during standing and that is relieved by walking. So for all of these, it is possible to consider functional neurosurgery for tremor as well. For these cases, though DBS is not actually FDA approved and would be off-label, the targets are quite similar. The most commonly used target is still the VIM thalamus. It is also possible to use the VOP thalamus or the ventro-oralis posterior nucleus, and also the new and upcoming target of caudal zona incerta. Right. So again, I think I emphasize this almost with every lecture. The main pathophysiology in movement disorders overall is oscillations. Something is wrong in the cerebellothalamo-cortical pathway, and the problem is abnormal oscillations. Right. So there's also been found to have for there to be an abnormal firing pattern in the VIM nucleus, and that is the cerebellar receiving zone. The problem does not lie in the cerebellum itself, but it lies in the fibers that are being received from the cerebellum in the VIM nucleus. Right, so as we have discussed, the most commonly used target for essential tremor is going to be the VIM thalamus, but other targets are also utilized apart from the VIM thalamus. The STN also can be utilized for targeting in the essential tremor patients. The best effect, though, of DBS is not achieved by targeting the STN itself. The STN is quite close by to the zona incerta, and it is actually targeting of the rostral or the caudal zona incerta that achieves the best effect and not targeting of the STN itself. The VIM thalamus is also the most common target, but again, the best effect is not achieved by stimulating the VIM itself. It is the contacts which are below the thalamus in the posterior subthalamic area. This is an area again quite close to the zona incerta. So there's still a little bit of confusion and doubt exactly as to what is the best area to stimulate to get the best response. But we're finding out more and more that the best targets are not within the thalamus or the STN, but actually with areas such as the posterior subthalamic area or the zona incerta. So the targets which are coming up and are becoming more important are the PSA and the cortisol inserter. So the PSA is basically an area which is located quite close to the red nucleus, to the STN and to the ventral thalamus, and this includes the zona incerta, the lemniscus, and the Forel fields. As we've discussed, cortisona inserta is becoming a very important target within DBS for tremor, and anti-tremor effects of this area are quite robust. The GPI as a target for tremor is only used for PD tremor, it is not used for essential tremors at all. Right. So, once a patient is decided to undergo treatment, which is surgical for tremors, that can be done either with ablation or with stimulation. It's important to remember that for all cases, if it is possible to stimulate, you would stimulate. Ablation is only considered for patients where they cannot undergo stimulation procedures, either because of cost factors or because of some of the other contraindication which exists for the placement of hardware within the patient. Right, so ablation procedures could either be done with radio frequency or there are other multiple different modalities as we'll see. So RF thalamotomy, all ablation procedures for tremor patients would again just usually target the VIM thalamus nucleus. For RF thalamotomy or for any other thalamotomy which is being done, the target for ablation is supposed to be 1 to 2 millimeters anterior to the target for DBS. This is because we want to completely avoid the sensory thalamus. With DBS, it's okay if the target is close because, again, remember, DBS is reversible. There's no permanent damage which is happening to the nucleus, but we cannot afford the same level of carelessness when it comes to ablation. So you have to be as far from sensory thalamus as possible, so at least 1 to 2 millimeters anterior to the same target you would be using for DBS. RF thalamotomy can be done under local anesthesia itself. First, what we do is we introduce a lead, stimulate using that lead, and if we find there are no responses indicating that we are within the internal capsule or within the sensory thalamus, and the second thing we're looking for is a complete arrest of the tremor, then we are sure we're in the right location and we can go ahead and produce an RF lesion, which is done at 75 degrees for 60 seconds. Similarly, a gamma knife thalamotomy can be done. This, as compared to RF thalamotomy, is completely non-invasive and requires only a single shot of 130 gray, which is obviously a lot higher than the usual gamma knife doses that we come across. With this, almost more than 80% have excellent or good effect on tremors. The only problem with gamma knife thalamotomy is that the response would take weeks or months. Okay, since it is gamma knife, since it is radiation, it is going to take quite a bit of time for it to act. Another problem that can happen is that some patients can develop massive edema and neurological deficits, usually over 6 to 9 months or over a year. As compared to gamma knife thalamotomy, MR guided focused ultrasound does hold promise. Okay, so just like gamma knife, it is a non invasive technique. The effects of MR guided focused ultrasound are immediate, unlike that of gamma knife. Okay, there's no risk of delayed radiation effects, and it works quite well. There's a 75% reduction in contralateral hand tremor scores. So we have discussed MR guided focused ultrasound in our epilepsy lectures, but just a small reminder. Basically, it is just a machine which creates focused ultrasound, and the entire process is guided by monitoring with an MRI real time. Right. So unlike gamma knife, it has immediate effects, and but like gamma knife, it is also going to be non-invasive. The only thing with MR guided focused ultrasound is it is quite expensive, and most centers do not still have MR guided focused ultrasound. Another technique which most centers do not currently have is MR guided laser interstitial thermal therapy. So we have discussed LITT quite in detail with our epilepsy lectures. So just a small reminder, basically laser interstitial thermal therapy introduces a laser electrode into the brain, and then it is heated up to a certain temperature, again based on MRI guidance. So it is invasive to a degree, but since it is just a small lead, it is minimally invasive. And real-time MR thermography will monitor the lesioning process. But for the use of MR guided LITT in movement disorders, it still requires further study. We just don't have enough data to say that it is safe and there are no problems. Right, so ablation can be done, as we have seen, with radio frequency, which is the most commonly used. And things which are growing now are gamma knife, MR guided focus ultrasound, and MR guided LITT. Right, so the other and more useful technique that we can use for tremor disorders is obviously deep brain stimulation. The main significance of deep brain stimulation is that it can be done bilaterally. Ablation procedures, especially in the thalamus, cannot be done bilaterally, right? So if you have a patient who has bilateral symptoms which are quite severe and disabling and refractory to medications, you would consider DBS as the first line treatment. Right, so DBS in tremor, as we have discussed, could target the subthalamic nucleus, but as we know, that is not the best target we want to use. Okay, you would be using the subthalamic nucleus for PD tremor and not for other tremor disorders. We've already discussed these values before, 3, 4, and 12. It is 3 millimeter posterior, 4 millimeter inferior, and 12 millimeter lateral to the ACPC line midpoint. So the mid commissural point, you have to take these values, 3, 4, and 12, and get to this plane. Okay, at this plane, you have to draw something called the Bijani line, that is a line drawn along the anterior border of the red nucleus. Okay, and where that line crosses the medial margin of the STN, 2 millimeter lateral to that is your target within the STN. That is what is the target for the sensory motor nucleus of the STN. Right? Remember, STN is just a target for PD tremor and not for other tremor disorders. What we're going to more commonly use for most tremor disorders is going to be the VIM thalamus. Right, so if you remember from the last talk, the targeting method that we had discussed previously was this one, where we took the ACPC line, 25% of the ACPC line length, and went posterior to the MCP, the mid commissural point, with that distance, right? And then 11.5 millimeter lateral to the ventricle. There's another method which is a little bit similar to this method, which can also be used, and this has been found to be slightly more effective. So you take, instead of 1/4, you take 1/3 of the length of the ACPC line, and you take that in front of the PC and not at the mid commissural point, and subtract 2 millimeters from that, and go about 13 to 14 millimeters lateral to the midline, and this is all at the level of the ACPC line. So again, nothing to just have to remember or memorize. These references exist, and there are two different ways that you could target the VIM thalamus. On the other hand, targeting for the caudal zona incerta is also again indirect, and the numbers to remember here would be 4, 8, and 12. It is 4 millimeters inferior, 8 millimeters posterior, and 12 millimeters lateral to the mid commissural point. Okay, so this is the red dot is what you want to target. As you can see, this is the red nucleus, this is the subthalamic nucleus, and quite close by here is the caudal zona incerta. Right, so this horizontal border is drawn at a junction of the red nucleus and the posterior tip of the subthalamic nucleus. This vertical line is drawn at the junction of at the lateral border of the red nucleus, and this oblique line is drawn along the medial border of the STN. So the distance between this vertical line and the oblique line is divided into 1/3, and this last 1/3 is the point where you're going to find this red dot. Again, a little bit complicated, nothing to memorize. Just know that this reference exists, and that is how you find the caudal zona incerta. Right, so once a patient does undergo DBS, there is quite a good effect that lasts for a significant amount of time, at least more than 10 years for these patients. For PD tremor, it has been found that with VIM and STN, you can achieve about a 75% reduction in tremors. But remember, VIM DBS, we do not do bilaterally, because even with DBS, there are side effects when it is done bilaterally, especially for PD tremor. For PD tremor, ST and DBS, on the other hand, can be done bilaterally, and it affords a 75% reduction in the tremors. GPI is going to be less effective at reducing tremors compared to STN or caudal zona incerta. And caudal zona incerta and posterior subthalamic area afford the highest rate of tremor reduction at 78 to 93%. Essential tremor, on the other hand, as compared to PD tremor, responds much better to DBS, and it can reduce by 90% with VIM DBS. CZI results, on the other hand, are better, but still we do not have randomized comparative trials to compare both the results as of yet. Right, so let's answer a few questions. Which of the following is true? DBS is indicated for refractory vocal tremors in essential tremor. VIM target for ablation should be 1 to 2 millimeters anterior to VIM target for DBS. Cerebellar tremor is also known as Holmes tremor. And a single shot of 100 Gray is given in gamma knife thalmotomy. Right, so the answer is number two. It is that VIM target for ablation should be 1 to 2 millimeters anterior to the VIM target for DBS. Right, and this is because we don't want to target the sensory part of the thalamus when we're targeting it for ablation. It's okay if we're doing it for DBS, but not for ablation. You want to completely avoid the sensory thalamus. Looking at the other options, DBS is absolutely not an indication, is not indicated, sorry, for refractory vocal tremors in ET. They do not respond very well to DBS. Cerebellar tremor is not what is also known as Holmes tremor. It is a rubral tremor, which is also known as Holmes tremor. And a single shot of 130 grays is given for gamma knife thalamotomy, not 100 gray. Right, so the second question we'll discuss is which of the following is used to evaluate the severity of tremors in ET? Is it the Burke Marston Fun scale, the Marston Hunt scale, the tremor severity scale, or the Fantaloso Marin scale? Right, so this is a very memorization based question, not really required to remember unless you're working exclusively with ET patients. The answer is Fantalosa Marin scale, which is what is used to evaluate the severity of tremors in essential tremor. Right, so the second part of the lecture today is the surgical management of dystonia patients, and let's get into that. We've already discussed the pathophysiology and mechanisms of dystonia and the basic clinical features in previous lectures. So we'll just discuss the management this time. So just a few basic concepts. Dystonia is classified into primary and secondary dystonia, and that is basically based on the underlying cause. If there's no obvious known cause, it is primary or idiopathic dystonia. And a secondary dystonia arises because of a structural abnormality or some or the other underlying etiology which has caused the dystonia. Overall, secondary dystonia is more prevalent. Okay, apart from this classification, dystonia can also be classified as focal if it affects a single muscle group. If it affects continuous muscle groups, it is segmental. If it affects discontinuous muscle groups, it is multifocal. Or it could just be generalized dystonia affecting all muscle groups. Right, so these, as we have discussed previously, dystonia can be managed either with medications or with surgery. So the medications include anticholinergic agents, dopaminergic agents, that is only for dopamine responsive dystonia, and GABAergic agents. It can also be managed with botulinum toxin to the particular muscle, so this is usually for localized dystonia. But even sometimes for generalized dystonia, you can give multiple Botox injections. And also with surgery. So it is important to perform these surgeries before secondary orthopedic complications arise because of dystonia and the contractions which set in. Right, so how do we select a patient for DBS in cases of dystonia? So the most responsive type of dystonia to DBS is isolated dystonia caused by DYT1 mutation. That is the best dystonia where you want to use DBS. Now, DYT1 dystonia can happen in two age groups. One is early onset at the age of 9 years, and one is late onset at the age of 45 years. The early onset begins with leg or arm dystonia, and a lot of these cases can become generalized. On the other hand, if it's late onset, it begins with neck or cranial muscle dystonia, and it usually stays in the localized region. And both of these patients will respond quite well to DBS. So a best candidate for DBS would be a patient who either has a primarily generalized segmental or cervical dystonia, is poorly responsive to medication or Botox, and is disabled due to motor impairment or pain. It's always important in cases of dystonia to rule out dopamine responsive dystonia. If a patient has dopamine responsive dystonia, they will respond very well to dopamine, and you do not require to provide any other treatment. So it's always important to give them a trial of dopamine, rule out dopamine responsive dystonia, and then only consider other forms of treatment. Apart from DBS, there are also multiple other surgeries which can be done. You can go in and you can cut off some of the nerves, so that's a peripheral denervation procedure which can be done, and this has been largely supplanted by Botox injections. You can also give chronic intrathecal baclofen infusions. You could consider an unilateral pallidotomy and ablate that. And what is most commonly used for surgical therapy now, that is DBS. Ablative procedures like a unilateral pallidotomy can improve some symptoms of primary generalized dystonia, but remember it is generalized, it is going to be bilateral. So it may not be sufficient. And as we know already, we do not perform bilateral pallidotomies because severe cognitive and speech effects which can arise. Right? So ablation for dystonia is not a very common treatment. On the other hand, DBS for dystonia is quite frequently done. So both GPI and ST and DBS have been approved for primary dystonia, and that is for patients who are 7 years or older. Remember, you want to target DBS for dystonia patients as early as possible to avoid orthopedic complications. So it is recommended for patients who are 7 years or older. Another important thing to remember, as we have discussed, is an adequate trial of levodopa has to be given before they are considered for surgery. Right. So just we have already discussed how the basic procedure of DBS happens in the last lecture series, but again, just a small reminder: before surgery, before the placement of leads, the patient undergoes stereotaxy. Stereotaxy can be frame-based or frameless. So I don't think we've discussed these particular topics in the last lecture. So just a mention of what is happening here. If it's a frame-based stereotaxy, remember there's a frame which is placed around the head. It is going to hold the head. It is going to immobilize the head. So there's a greater head stability that itself provides a higher level of accuracy. And because you're using a frame, it is compatible with micro electrode recordings because you can introduce those through the frame. You can also go around choosing multiple different entry points and have a flexible trajectory because you just have to change the values and calculate different stereotactic entry points. It is going to be of a lower cost than using frameless stereotaxy, and we overall have more experience with using a frame than not using a frame. Frameless does have the really significant advantage though of it being more comfortable for a patient. Also, another thing it can do is with intraoperative MRIs and CTs, it can adjust for brain shift. Brain shift, it's a phenomenon which can happen with any surgery, but we really want to avoid doing it in cases of DBS. But if it does happen, having a frameless stereotaxy would have helped more than having a frame-based stereotaxy. Right, so once the patient undergoes a stereotactic procedure of frame-based or frameless stereotaxy, then a CT or MRI is done to define your targets and trajectory. And after that, a burr hole is placed, and if the patient is on a frame and is awake, MER leads are placed, right? So the most common target would be GPI for dystonia patients. You're going to target 2, 4, and 21 relative to the MCP. That's 2 millimeter anterior, 4 millimeter inferior, and 21 millimeters lateral to the MCP. The trajectory is again decided by the stereotactic calculations. Is usually 60 degrees in sagittal plane and 10 degrees in the coronal plane. Once you get into the GPI, you're going to get the MER recordings and confirm that you've entered the GPI. So we have discussed this in the previous lecture section as to how that is done. Once you have got the recordings, you know which area is a sensory motor area of the GPI. You can stimulate in that area, look for the DBS effect, and look for side effects. Right. So the thing with dystonia is that unlike PD, the stimulation will not act immediately. So looking for intraoperative effects of stimulation does not work for dystonia. Right? So it's not necessary that you go in and you look that dystonia is resolved during the surgery itself with the placement of the lead. Right? So if the MER recording shows that you're within the sensory motor GPI and up to 4 volts of stimulation has no adverse effects, you can just leave the lead in there. There's no need to reposition it just because you're not getting an effect on the dystonia. All dystonia patients are evaluated with this scale, the Burke Fan Marston Dystonia Rating Scale, or the BFM-DRS, and with DBS there have been improvements of 60 to 70% on this scale. And this response is quite long lasting. It lasts for at least 10 years. The usual complications of DBS obviously do apply. Infections can happen, hardware complications, and rarely some very unusual complications of depression, neck pain, and even de novo Parkinsonism can arise. Other targets for dystonia do exist. Remember, but most important thing to remember about dystonia is that the only target to remember is GPI. These targets are very rarely used. So the thalamus is used as a target for dystonia, only for secondary dystonia, and you could use the VIM, VOA, or the VPL nucleus. Further studies are required to evaluate what is happening with the role of STN in dystonia. But again, just remember GPI for dystonia, and that is enough. Other surgical options which could be done are peripheral denervation only for cervical dystonia. You go in, you section the branch of the accessory nerve supplying the sternocleidomastoid and all the posterior rama of the C1 to C6 spinal nerves. So that can also lead to clinical improvement of cervical dystonia, and that improvement is seen in 70 to 90% of patients after this procedure. Right, so a question about surgical therapy of dystonia, which of the following is false. DBS is indicated for medication refractory dystonia for all patients more than 25 years of age. 60 to 70% improvement occurs in BFM and BFM DRS following DBS. Frameless stereotaxy is less accurate than frame-based stereotaxy, and an adequate trial of levodopa is necessary before considering surgery for dystonia. Right, so the answer is one, as we have discussed, treatment for dystonia should be as early as possible, and it has been approved by the FDA at the ages of 7 years or older. So it is not 25. So it is indicated for dystonia patients who are refractory to medications more than 7 years of age. 60 to 70% improvement does occur following DBS in BFM DRS, and frameless stereotaxy is going to be less accurate than frame-based stereotaxy. And an adequate trial of levodopa is absolutely necessary before you consider surgery for dystonia. Right. So we're just going to go over just a basic discussion of functional neurosurgery for other disorders. It can seem a little complicated and difficult to remember. Just remember that you don't have to memorize everything which has been discussed here. A lot of it is just random words thrown around, but it exists here for reference. You can always come back to it and look at it later. And a lot of it is still under evaluation and still under trials. And we have to still see how we progress with that. On the other hand, a few of these disorders are being managed with surgery, and that is happening quite frequently. One of these includes Tourette syndrome, and indications have been established for Tourette syndrome. So, Tourette syndrome is evaluated with the Yale Global Tic Severity Scale. So, we have discussed Tourette syndrome previously, and the proposed selection criteria to choose a patient for DBS in Tourette syndrome are as follows: that there have to be at least two physicians who have established a definite diagnosis of Tourette syndrome. The patient should have severe and incapacitating tics. It should be treatment refractory, and that is defined. There should be a poor response to at least three different medications, and each should have been tried for at least 12 weeks. There should have been at least a trial of 10 sessions of behavioral therapy, but this patient should be at least 25 years or older. Right, so in cases of Tourette syndrome, DBS will improve both the motor and the vocal tics. There is a bunch of potential targets which exist. There's a medial thalamus, the GPI, the GPE, the internal capsule, or the nucleus accumbens can also be used. The STN can also be used. So between all of these, the best target is really not established. Any of these can be used for the purpose of treatment in Tourette syndrome. On the other hand, with obsessive compulsive disorder, 10 to 25% of patients are refractory to medical treatment, and so they could undergo DBS. The evaluation of OCD is done with Yale Brown Obsessive Compulsive Scale, or what is known as YBOX. Surgery is considered if OCD is refractory and YBOX is 28 to 30 or more. With DBS, about 40 to 60% of patients will respond, and there will be about a 35 to 45% reduction in YBOX following DBS. There are multiple options again for OCD. Okay, so there are only two things you really have to remember. The FDA approved nucleus is the anterior limb of the internal capsule, but the nucleus that is preferred for OCD currently is the ventral capsule by the ventral striatum. Other nuclei can also be used, the nucleus accumbens, the STN, and the inferior thalamic peduncle. But if you have to remember two for OCD, it would be the anterior limb of internal capsule, which is FDA approved. But the preferred nucleus is the ventral capsule or ventral striatum. Apart from DBS, other options which can be used are ablation. So that can either be done with RF or with gamma knife or with focused ultrasound. So there are multiple different areas we can target with OCD. In OCD, you can do a cingulotomy, a capsulotomy, a subcaudate tractotomy, or a limbic leucotomy. You can also target the capsulotomy with gamma knife and focused ultrasound instead of RF lesioning. Treatment can also be provided for major depressive disorder. So it is important to remember that the dysfunction again in all of these disorders lies in the same pathway. the limbic frontal striatal thalamic frontal loop. Okay, so 20% of major depressive disorders will be treatment refractory, and that's where DBS or ablation can be considered. Right, so DBS for major depressive disorder, on the other hand, can be done in the subcallosal cingulate cortex, the ventral capsule or ventral striatum, and the medial forebrain bundle. Again, nothing to memorize over here. Just remember that there are multiple nuclei which we can target, and the reference here exists if you ever want to look at it again. Ablation can again be done with RF, gamma knife, or focused ultrasound. Again, it could be a cingulotomy or a capsulotomy. We are doing surgery even for anorexia nervosa, okay, and DBS there can target subcallosal cingulate or nucleus accumbens. There is a easy way to remember this. So since it's anorexia nervosa, you could remember SNAC. So S stands for subcallosal cingulate, and NAC is for obviously nucleus accumbens. So that is a way to remember the targets over here. Ablation can also be done for anorexia nervosa, again targeting the same substrates that we were targeting in major depressive disorder, capsulotomy or a cingulotomy. So these targets, capsulotomy or cingulotomy, are going to be common through anorexia nervosa, major depressive disorder, and even for OCD. Addiction, right? So again, remember the main nucleus when it comes to addiction pathophysiology is the nucleus accumbens, and DBS of the nucleus accumbens is being tried again for addiction. So another way you could remember this is NARC. So that's what usually we remember when it comes to drugs, and so NARC is quite close to NAC. So if that's a way you can remember that nucleus accumbens is being targeted for addiction. Right, so some other disorders apart from just psychiatric disorders are also targeted with surgery. So obesity is one of these. There's a high complication rate with gastric banding and gastric bypass. Those are usual surgeries done for obesity. So DBS has been tried in obesity. Okay, and these usually targets the centers which are responsible for appetite. So the lateral hypothalamus, the ventromedial hypothalamus, or the center responsible for providing dopamine when you eat. So the nucleus accumbens. So human studies have been done only on the lateral hypothalamus, and they have shown a decreased hunger urge and improved energy. If we know whether this will translate into actual treatments for human beings, we don't know yet. We have to see and figure out as time goes on. Surgery can also be done for Alzheimer's disease. There are multiple options with that. Gene therapy could be done. There's an ongoing phase 2 trial of this enzyme, which provides gene therapy. Vagus nerve stimulation has been found to have some benefit. DBS of the fornix and the nucleus basalis of Mannert have also shown some effect in Alzheimer's disease. Right, so that more or less covers the topic for today. Just I think we have missed out a little bit of a discussion on the recent advances in PD treatment with the last lecture, so I wanted to cover those. There are a few advances which have happened in Parkinson's treatment, but more or less currently worldwide, the most common used treatment is going to be regular DBS. There are a few advancements which have happened in DBS itself. Right, so there's a closed loop stimulation, which is similar to the idea of responsive neurostimulation. Basically, the leads that we place in the brain are both sensors and stimulators. So they pick up whatever activity is going on in the local neurons, and with that activity, they decide whether they want to provide stimulation or not. So when there's no abnormal activity happening, stimulation will be switched off. So this is to avoid side effects. When abnormal activity happens, then stimulation can be switched on as to provide the DBS effects. Right, so these are context-aware systems. More commonly, this closed-loop stimulation or responsive neurostimulation is used in epilepsy. That's when epileptogenic signals are picked up and directly stimulation is provided to cut off those signals. But it is also being tried with DBS. There are electrodes which can also current steer. So instead of putting out current in all directions, they can generate directionally selective electric fields. And this allows you to target the nucleus you want even more precisely. Apart from DBS, there are other advancements which have happened. That is, again, focused ultrasound lesioning can be done. It is similar to all other forms of ablation and PD. Transplantation of fetal midbrain tissue, but then, this is an ethically significant problem. Stem cells, that is human embryonic stem cells or induced pluripotent stem cells, can also be transplanted. And gene therapy is also being tried for PD. So again, these are recent advances, maybe might take decades before they actually come into clinical picture. Right, so a question for this section: which of the following is true? DBS does not improve vocal tics in Tourette syndrome. There's a 35 to 45% reduction in Y-box following DBS for OCD. DBS for nucleus accumbens is being tried for Alzheimer's disease. The medial hypothalamus is a good target for DBS and obesity. Okay, so the answer is 2. There's a 35 to 45% reduction in Y-box following DBS for OCD. Okay, so I can understand why there might be a slight confusion regarding option number 1. So DBS does not improve vocal tics in Tourette syndrome is not correct. It does improve both motor and vocal tics in Tourette syndrome. It does not improve vocal tremors in essential tremor disorder. Okay, so that's where confusion can arise. But in Tourette syndrome, it improves both motor and vocal tics. DBS for nucleus accumbens is not for Alzheimer's disease. Okay, we are targeting the nucleus basalis or Maynard for Alzheimer's disease and the fornix instead. The lateral hypothalamus is a good target for DBS and obesity, not the medial hypothalamus. Which of the following treatments is ideal in a patient with Parkinson's disease of 4-year duration, moderate cognitive impairment, tremor predominance, and severe dyskinesias? Would you target the GPI? Would you target the STN? Would you do a palidotomy? Or would you continue medications? Right, so the answer is to continue medication. The only indication in this entire description to continue medication is the duration of Parkinson's disease. Okay, the same patient are presented with a 6-year duration on the other hand, you would consider GPI DBS. Okay, because GPI DBS is good for patients who have some cognitive impairment and who have severe dyskinesias. If they did not have cognitive impairment and they did not have significant dyskinesias, we would consider STN DBS instead. Yeah, so that is all for today's lecture. Thank you so much for attending. This